So after going through the multiple gestation discussion, let's talk about another very important topic in obstetrics, that is postpartum hemorrhage. So in this topic, we talk about what is postpartum hemorrhage, what are the causes or the risk factor, okay, followed by how to manage. Every obstetric students or the doctors who are working in the delivery room must know how to manage postpartum hemorrhage, because this is one of the most common cause of maternal mortality all over the world. Now see there, before I go into the discussion of postpartum hemorrhage, you should remind yourself about some common complication of third stage of the labor. First, let me ask you, what is third stage of the labor? Yes? What do you mean by third stage of the labor?
So delivery of the placenta and the membrane.
The delivery of the placenta and the choroid membranes are remaining inside.
Very good. Excellent answer. I'm sure 100% of the students know this. Third stage of the labor means delivery of the placenta and the membranes. So, these are the complications which can happen there. One is postpartum hemorrhage. That's what we are going to talk in this class. Another is retention of the placenta. The placenta doesn't come out if it retains inside the uterus. Another is pulmonary embolism, especially amniotic fluid or air, because some of the blood vessels may remain open there, especially air embolism. And uterine inversion can also occur if it is not properly managed, especially if they, continue to give traction on the umbilical cord and try to pull the placenta out, then inversion of the uterus can also happen. Okay, so these are the complication, but the most important one has to be postpartum hemorrhage. Now, what is the definition? If the blood loss is more than 500 ml at the vaginal delivery and more than 1000 ml at cesarean section, we call it postpartum hemorrhage. Very easy definition. Blood loss more than 500 ml at vaginal delivery and more than 1000 ml at cesarean section is called postpartum hemorrhage. According to ACOG, American College of Obstetrician and Gynecologists, ACOG, if there is 10% drop in hematocrit, okay, or if there is need for any blood transfusion after the delivery or cesarean section, then it is a postpartum hemorrhage case. This is a bit of practical definition. And another one, a severe PPH in case of vaginal delivery means if the blood loss is more than 1000 ml or 1 liter. This is known as severe PPH in case of vaginal delivery only, because in case of cesarean section, for the definition itself, we need more than 1000 ml blood loss. Now, there are some problem here. What is the problem? The problem is, how do we know exactly that 500 ml blood is lost, 600 ml, 700 ml, 1000 ml, like that? Okay, so this is a big practical challenge for all of us. So most of the time, the estimate of blood loss is notoriously low. So let's talk about that. There are, however, some problem with this definition, and this is because of poor estimation of the blood loss. The estimate of blood loss are notoriously low at the time of delivery. Often it is half of the actual loss. If there is 1000 ml blood loss, we may only get 500 ml loss in that suction bottle or something like that. So it is notoriously false or low than the real blood loss. Blood is mixed with amniotic fluid and sometimes with urine also, and we don't consider that as a bleeding. It is dispersed on sponges, towels, and linens, and it is also in the bucket, inside the bottle, or also on the floor. And many of the times we tend to ignore that bleeding. So that is the meaning for it is notoriously low estimate after the delivery. Okay. The importance of a given volume of blood loss varies with the woman's hemoglobin level. If the lady is already anemic, then even a small amount of blood loss, okay, can be fatal for her. If she is not anemic or a healthy, lady, means hemoglobin is well above 10, then it doesn't cause a lot of problem to her. So it also depends what is the hemodynamic status of that lady. Risk assessment in the antenatal period doesn't effectively predict those women who will have PPH. So we cannot predict, who are the women who have PPH and who are the women who doesn't develop PPH. There are some type of risk factor which are known, like just now you have studied about multiple gestation or multiple pregnancy. Yes, the chance of PPH is more in that type of situation, but we are talking about singleton pregnancy here. Just one baby is inside, and I cannot foresee, oh, this lady may develop PPH and this lady may not. Okay, so it is purely known at that time. Let's move on. Now, there are two types of PPH. One is called primary postpartum hemorrhage, and another is secondary postpartum hemorrhage. Primary and secondary. Please mute yourself. Primary and secondary. Now, what do we mean by that? Primary PPH is also known as immediate PPH. That means within the first 24 hours of the childbirth, there is vaginal bleeding. And this is, of course, fulfilling the criteria. Whereas secondary is also known as delayed PPH. There is increased vaginal bleeding after the 24 hour of the childbirth. That means within the puerperal period. Now, puerperal period means up to 6 weeks after the delivery. Okay, that is called puerperium or puerperal period. That is after 6 weeks, I should say, till 6 weeks after the delivery. Now, during this phase or time period, all the changes which occurs in that female's body will come back to the normal. The uterine size will come back to the normal size, and all the physiological arrangement which has happened during pregnancy will come back to the pre-pregnancy state. So this is called puerperal period. If bleeding occurs during the time, we call it secondary PPH. Now, what are the causes of primary PPH or immediate PPH? Okay, PPH is the term for postpartum hemorrhage. Okay, so this is very commonly used short form. Now, these are the common etiology. See there, please pay attention. This is very important class, and you will get a very clear concept right from this class. The first thing is tone. Okay, see that there are 4 T's here to make it easy for you. This is one of the way of answering in the exam, and another way is also there. I've included, which we'll talk. But let's focus now. Tone is the most important, cause of PPS. Tone means atonic uterus. Okay, to make it easier for you, it is written like that. But atonia or atonic uterus, when uterus is not contracting properly, is the most important cause of postpartum hemorrhage. There are spiral arteries inside the uterus, and these spiral arteries has to be compressed because of the myometrial contraction. If this is not happening, then there is a high chance of bleeding. And there are so many causes of atonic. We'll talk about that. Second is a tissue. Okay, tissue. Now, what do you mean by that? These are retained placental fragment. Retained placental fragment. Okay, so if a placenta is not completely delivered outside, if some pieces of the placenta are left inside, then uterus cannot contract properly. We have already discussed that multiple times before. Retained blood clots in an atonic uterus or gestational trophoblastic neoplasia like hydatidiform mole, which is also known as molar pregnancy. They are grape-like substances or tissues which are present inside the uterus. If 1 or 2 are left behind, then also, okay, these comes under retained type of tissues, and they really can cause postpartum hemorrhage. Third is trauma. Now, laceration of the cervix, okay, laceration of the birth canal, episiotomy. You all know what is episiotomy, yes? Let me ask this question. What is episiotomy?
Sir, episiotomy is an incision made in the sir, made in the perineum during childbirth or labor.
Exactly. Exactly. If you answer like that, yes, you are absolutely right. So remember, we have discussed this during the topic of childbirth. Okay, during the topic of delivery, episiotomy is cutting of the perineum. Cutting of the perineum. Usually, it is done in mediolateral direction, but these days there is a bit of controversy regarding the episiotomy. Some obstetricians believe the natural tear is better than the episiotomy. Okay, it's all depends on how they think, and what is the common criteria, okay, in that hospital. What is the protocol in that hospital? It all depends on that. But it will definitely makes that birth canal bigger, episiotomy. And after the birth of the baby, we have to suture it quite well. That episiotomy can also bleed. So this is a cause of PPH. Uterine rupture or inversion is another cause of PPH. Rupture, okay? Rupture is quite common, especially if the first or the prior delivery is done by cesarean section, and usually the classical type of cesarean section. That means the incision is given in upper uterine segment. This is not commonly done these days. If it was done before, then there is a high chance of uterine rupture in this pregnancy. Thrombin. Okay. The fourth one is the thrombin. That means some bleeding disorder. Some bleeding disorder. Look at the causes here. DIC, disseminated intravascular coagulation, hemophilia, or von Willebrand disease. All of them, if the lady is suffering from them, then also there is excessive hemorrhage after the pregnancy or during the delivery or after the delivery. Now let's elaborate a bit about them again. Now, see this. Okay, this is other way by which you can answer this question. If your teacher asks, what are the causes or etiology of primary PPH or immediate PPH? These are the way you can answer. The first is atonic uterus. This atonic uterus is very common in grand multipara. Okay, grand multipara means she has given birth to so many babies. Okay, already 5-6 babies, and the age of that lady is also a little bit more. Over distension of the uterus by multiple pregnancy, polyhydramnios or hydramnios is the same term, and a large baby because the uterus is overstretched there or over distended. Malnutrition and anemia. APH, antepartum hemorrhage, especially abruptio placentae. Prolonged labor, okay, the uterus can become atonic. Retention of the placenta or bits of placenta or membrane which are left inside. The uterus would be atonic again. Malformation of uterus like septate uterus or bicornuate uterus, it cannot contract properly. These are some of the congenital anomaly which may be present already inside the uterine cavity. Okay, septate uterus, bicornuate uterus, there are different types. Mismanaged third stage of the labor. So all of these can be the different causes for atonic uterus. Okay, and remember, when the uterus is atonic, we have to give some contracting agent to stimulate the contraction of the uterus so that the bleeding will be stopped. So what are those agents what I'm talking right now? What are those drugs which could increase the contraction of uterus? Yes?
Oxytocin, sir.
Misoprostol,
No,
mifeprostol, prostaglandin.
that oxytocin and prostaglandin, sir.
Misoprostol and mifeprostol.
Very good, very good, excellent. You have already answered the two of the important drugs. Okay, one is oxytocin, another is prostaglandin. The third one, which you are going to know in this class, is known as orgometrine. Orgometrine. This is also sympathomimetic type of drug, which will cause contraction of the uterus. We are going to take these names again later on in the management part. Now, second, okay, is a trauma. Already talked about laceration of the genital tract during childbirth and episiotomy bleeding are the important one. Combine atony and the trauma and blood coagulation disorder. Okay, so these are some other. So uh, uh, the two different ways are taught to you. So whatever is easy for you, you can answer like that in the exam. There is no hard and fast rule here. Now, how to diagnose a case of postpartum hemorrhage? See this. Let's combine everything together. Diagnosis always comprises of symptom and sign. That is one part of your diagnosis. Okay, this is the clinical examination followed by investigation. So history taking is the symptom, physical examination is the sign, and investigation is the lab test. So all of them combined together, you reach to the diagnosis. So there is increased vaginal bleeding within the first 24 hours after childbirth, and this is excessive of 500 ml. Then the definition of PPH is fulfilled. There may be features of hypovolemic shock if the bleeding is excessive, and you all know those features. Yes, anybody? What are the features of hypovolemic shock? Yes? Okay. The features of hypovolemic shock. It's the
Sir,
most.
we've got sir,
Yes,
may I,
yes.
sir?
Yes, yes, sure.
Like sir, the sign and symptom of hypovolemic shock, like sir, we've got sir, like sir, a shallow breathing, sir, we've got tachycardia, a very rapid heartbeat, sir, like we've got fatigue, sir, we've got like weakness, sir, we've got confusion, sir, due to less supply to that to a nervous system, and sir, we have hypotension and we have cool and clammy skin.
Okay, good. Any other student want to add? Yes, please. So important points he has already mentioned there. Okay, so let me summarize quickly. Hypovolemic shock occurs because of excessive bleeding in this case. So in the beginning, there may not be hypotension. The blood pressure may still be normal. But if the bleeding is excessive, the blood pressure may also fall. After the blood pressure falls, we call it decompensated shock. So the common features would be tachycardia, very important feature, tachycardia, excessive sweating, okay, cold and clammy periphery, confusion, okay, oliguria. All these are important, physical findings. Then once the lady is entering into the decompensated stage, it is difficult to treat. On examination, now the important features of the PPH itself or the causes, uterus may be soft and not contracted if the cause is atonic uterus. So we need to always, place our hand on the anterior abdominal wall and try to feel whether the uterus is contracting or not. If it is not contracting, got the diagnosis. This is because of atonic uterus. But there are so many causes of atonic uterus, so that is a real another challenge. Portion of maternal surface of the placenta may be missing or torn membranes with vessels. This is the feature of retained placental fragment inside. So if this is the case, then exploration of the uterine cavity has to be done and try to, take those retained fragment outside. Sometimes it is another big challenge. Sometimes the retained placenta is not inside the uterine cavity, but they are inserted inside the wall of the uterus, like placenta accreta, placenta increta, and placenta percreta. And in those situations, we have to go for surgery. If placenta is not delivered within 30 minutes after the delivery, we call it retained placenta. This is the definition. This is a part of today's lecture, I'll cover this a bit later again. Now, during examination, we have to examine for cervical tear, vaginal tear, or even perineal tear. These are the trauma which can result in PPH. So you always need to examine them. Who knows? You are only thinking about the atonia, but but sometimes, the combination of the things may be happening there. You have controlled the atonic uterus by giving drugs, but still the lady is bleeding. So she may bleed from the cervical tear or this type of tear. Now, after the diagnosis, let's talk about the management, how a case of postpartum hemorrhage is managed. Now, in the beginning, we have to go for the general management because this is a case of bleeding. Who knows, the lady is already in shock. Okay, so manage that appropriately. Perform a rapid evaluation of the general condition of that lady, general condition of the woman, including vital sign like pulse, blood pressure, respiration, and temperature. Pulse oximetry is not very important in this case, but these four are always be taken. Okay, so most important one are pulse and blood pressure in this case. After she has developed metabolic acidosis, the respiration may also be affected. If shock is suspected, immediately begin the treatment, like start the IV infusion and infuse the IV fluids. So which IV fluids you want to give here? Which IV fluids?
Sir, ringer lactate.
Exactly. Ringer lactate or normal saline. Okay, you can answer like that because these are called crystalloids. If hemoglobin is less than 7, means severe anemia. This is the definition of severe anemia. Or hematocrit is less than 20%, then arrange for a blood transfusion. You need blood. You need to give blood during this time. So from where we get blood now? Yes, a bit of practical discussion. Who will give the blood here? Who?
Sir, from siblings, sir.
Okay. If siblings are not there, then
we will by cross matching checking the blood.
The cross matching the blood of any donor, and if it matches, sir, then we can give it. But sir, depending on the time presence at that time.
exactly. Now listen here, okay? Because you are going to be doctor very soon. You are going to work in the hospital. So this fact has to be understood. Remember, you have to foresee this thing. Foresee means you have to, see these things are going to happen, sometimes later. And at that time, you have to make everything ready. If this lady needs blood, the blood has to be there as soon as possible. And that may not be possible if you decide only that time. So that is the meaning of foresee the things. Now there are different sources of the blood. One is blood bank. The blood bank, okay, is present right inside the hospital, in the big hospital. It is present there, or sometimes it is present in some part of the city. So we can quickly go there. We already have done the blood grouping of the patient. Okay, then the blood has to be brought according to the appropriate group, and cross matching has to be done and then given to the lady. This is one way. Another one, if there are some relatives, some friends who are accompanying, then we can quickly check what is their blood group. If it is matches, then they can donate the blood at the time, and then we can give to that lady. But cross matching has to be done before every type of transfusion. Catheterize the urinary bladder. This is the very important step. We should never forget it. There are different advantages of catheterization here. One, remember, this is a case of hypovolemic shock or hypovolemia. So we must know how the kidneys are working. What is the amount of urine output? That is one way, one advantage of catheterization here. And another one, if the bladder is full, that full bladder probably will disturb the contraction of the uterus. Okay, it will disturb the contraction of the uterus. It will also disturb during the examination part. For example, you are going to examine whether there is cervical tear or not, whether there is vaginal tear or not. During that time also bladder should be empty. Okay, and during the management also it will disturb if it is distended. So catheterization has to be done, and that is usually done by Foley's catheter. Now check to see if the placenta has been expelled and examine the placenta to be certain it is complete. You should always, quickly examine the placenta, always, if it is completely come outside or not, whether some pieces are still left inside or not. Until and unless you examine, you never know. And examine the cervix, vagina, and perineum for the tears. These are the general management point. Now, what are the specific management according to the cause now? If the cause is atonic uterus, how can we manage? The meaning of atonic uterus is it is failed to contract after the delivery. So you continue to massage the uterus, okay? And by massaging, the uterus may start to contract again. This is a very simple management but very effective one. At the same time, we go for the use of oxytocic drug, means those drugs which help the contraction of the uterus. So what are these drugs? So let's know the name. Okay, see this? These are the oxytocic drug we have. Oxytocin, orgometrin or methyl orgometrin, and prostaglandin. Okay, though it is written 15 methyl prostaglandin, you can simply remember prostaglandin. Okay, there are different types. Here is written of F2 alpha, but other prostaglandins are also there. All of these are oxytocic agent. So you don't need to remember this detail. These are all purely practical information. At this stage, you just remember the name of the drug. If your examiner asks, can you tell me which are the contractile drug for the uterus or known as oxytocic drug? These are the names: oxytocin, prostaglandin, orgometrin, or methyl orgometrin. Now, if bleeding continue, okay, even with this type of management, what should we do? Okay, now this is a complicated situation. So what should we do? Check placenta again for the completeness. Maybe in the first examination you have missed, maybe one small bit or piece of placenta is left behind. Maybe membranes are left behind. You check it again. If there are signs of retained placental fragment, okay, then remove the remaining placental tissue by exploration of the uterine cavity. So you put a forceps inside, okay, or a curette inside and do those things. Assess the clotting status using clotting test and manage accordingly. Diagnose whether the lady is having bleeding or clotting disorder or not. Okay, and just in some other classes recently you have studied those things. So we always start from CBC here. CBC. After CBC, you go for bleeding time and clotting time. And only if they are abnormal, you go for some factor assay. Okay, otherwise you don't need to do those things. Let's move on. Now, if bleeding continue even after these steps, what should we do? Okay, sometimes some unfortunate cases, bleeding keep on happening. Then what is the next management? See here. If bleeding continue in spite of the management above, perform bimanual compression of the uterus. Bimanual compression of the uterus. Now, what do you mean by that? Bimanual means both of your hand are used to compress the uterus. So wearing high level disinfected or sterile gloves, insert a hand into the vagina, okay, and remove any blood clot from the lower part of the uterus or the cervix. This is the first thing. Second step is form a fist and then place the fist into the anterior fornix of the vagina and apply pressure against the anterior wall of the uterus. Okay, this is the next step. And with the other hand, because this is a bimanual compression, remember both hands are used here, press deeply into the abdomen behind the uterus, applying pressure against the posterior wall of the uterus. and maintain the compression until bleeding is controlled and the uterus contract. So let me make it very simple for you. Both of your hands are used to give compression of the uterus. And we hope the uterus starts to contract because of this maneuver, and the bleeding will be stopped. One hand, okay, is put into the anterior fornix. Fornix is a part of the vagina. Remember that it had different folds which are called fornices. Posterior fornix is the deepest one. Anterior fornix is on the anterior side. So you put one hand there, make a fist, and apply pressure against the anterior wall of the uterus. Okay, and then one hand is put on the anterior abdominal wall. Then you press it backwards. So this is the way. Now, what is the other way? If this also fails, let's talk about this. If this also fails, then what else we can do? Alternatively, you can compress the aorta. Okay, this is the abdominal aorta we are talking about. So apply downward pressure with a closed fist over the abdominal aorta directly through the abdominal wall can be done. Now we can all palpate or feel the pulsation of the abdominal aorta. Okay, we can feel that. It is very easily felt, especially in the thin type of person. But during pregnancy also, though the uterus is there, we can give a firm pressure and we can still feel the pulsation, because abdominal aorta is a very large artery. So give a firm pressure there. And how you know the pressure is enough? See this. If the femoral pulse is palpable during the compression, the pressure is inadequate. And if the femoral pulse is not palpable, the pressure exerted is adequate. But we need to, make sure the pressure is given for a good period of time. Don't worry about the ischemia. Ischemia doesn't happen so easily. Okay, but after a few minutes, that bleeding would be controlled, and then you can release the pressure. Now look at this. Okay, this is the way in the picture form. This is called bimanual compression of the uterus. Look at the hand here. Okay, one hand is making a fist inside the vagina, in the anterior fornix of the vagina, and then another one is pressing the anterior abdominal wall. So this is called bimanual compression of the uterus. Another is, see this, compression of the the abdominal aorta by giving pressure on the anterior abdominal wall. So both these can be done, but they are not done in the early stages. When the routine procedure fails, then we go for this. If bleeding continue in spite of this type of compression, what else is the option for us? What can we go for then? See here, perform uterine and utero-ovarian artery ligation. Now this is a big type of surgery. Perform the uterine and utero-ovarian artery ligation. If you, ligate the uterine artery or the ovarian artery, then there will be no bleeding, because the source of bleeding here is from the uterus. If life-threatening bleeding continue even after ligation, perform subtotal hysterectomy. So, usually bleeding will be stopped by this type of ligation. Okay, but some of the surgeon, they don't want to go for this ligation, rather they can go for hysterectomy. Subtotal type hysterectomy means from the area where the bleeding is coming, okay, we sacrifice that part of the uterus, or sometimes the whole uterus can be sacrificed. This is called total hysterectomy. Now this is a very challenging type of surgery. Okay, you all know it depends on so many factors. One, what is the family status of that lady? What is the age of her? What the family thinks? Having said that, saving the life of this lady is the most important thing for the doctors. Okay, So all others are secondary things at this stage. Saving the life is the most important one. So if necessary, we need to go for this, very difficult decision also. Now let's move on. What are the other specific management? For example, if the tears of the cervix, vagina, or perineum are the cause of postpartum hemorrhage, what should we do? We should go for the repair. You go for the repair of these different type of tears. Very easy answer. So find them out by the good examination and repair them. Sometimes atonic uterus may coexist with this type of tear. So we have to manage both. And still after the repair, if the lady continue to bleed, then assess the clotting or coagulation status. Who knows? She is already in DIC. Who knows? She is having some bleeding or clotting disorder, which we failed to diagnose before. So those are the important points which come in the mind of that treating doctor. Now, there is one small picture which is included here, okay, and it is showing the diagnosis of a cervical tear and suturing it. Okay, we have to find the apex of the tear. Apex. If you miss the apex, the bleeding will continue. Find the apex, give the first suture through the apex, and then slowly come downwards. Okay, this is called how to repair the cervical tear. Talking about how to manage a case of postpartum hemorrhage, and this is just a summary of that. We have done the detailed discussion, so we need the help of more than one person here, and of course there are doctors and nurses during the management or in the management team, and there is no lack of the personnel there. So the main person will do all these things, rub the contraction, means massage the uterus so that the uterus will be contracted, empty the urinary bladder, and all these things, call for help so that the other person will do those things. See this, okay? This Hartmann solution is the another name for ringer lactate. So don't get confused. Sometimes this is the term which is mentioned in the book. This is the ringer lactate. Syntocinon means oxytocin. This is the trade name of oxytocin, which is very commonly used all over the world. Syntocinon. Okay, other things are quite familiar. Now see this. When you are massaging the uterus, if the uterus is felt very hard, that means there is no problem of atonia. Uterus is having good contraction. Then you should think about probably some other causes are there for postpartum hemorrhage, like trauma. Okay, like trauma, probably cervical laceration, vaginal laceration, something like that. So suture those things after diagnosing them. Or who knows, the lady may be having some coagulation disorder or bleeding disorder. The thrombin is the meaning for that. Okay, just to make it easy for you, the term thrombin is written there. So make sure she gets fresh frozen plasma and the necessary factors, but you need to diagnose it first. Then only you can go for the factor supplementation. And during the examination, if the uterus feels boggy, boggy means it is not well contracted uterus. It is a bit of uh, uh, poorly contracted uterus or flaccid uterus. That is a good term. Flaccid uterus, boggy. Then we need to give some oxytocic drug. Oxytocic, like oxytocin, like prostaglandin, or maybe ergometrine. So see this. If it is still bleeding, then these are the things we are going to do. Bimanual compression, already talked about. Use of misoprostol, a type of prostaglandin. Carboprost, another type of prostaglandin. And oxytocin, already talked about these things. So we should go for this. And if it's still bleeding, then we can go for some bigger types of management like B-Lynch breast suture, hysterectomy, and uterine or internal iliac artery ligation. Now, these second and third are well known to all of you, but what is the meaning of this first, management, B-Lynch breast suture? So to explain that, I have included a picture here. The picture is self-explanatory for you. See this. This is the way the uterus is sutured here. Okay, see this? This is a big type of suturing of the uterus, and this will clamp down all the blood vessels of the uterus, and the bleeding will be stopped. This is never done in the beginning. This is only done when the bleeding is still persisting and when it is very difficult to control. Now, with this, let's move on to the discussion of retained placenta. But a lot of the things we have already discussed before. Remember the topic of delivery. During that time also we talked something about that this one. So it is a good easy concept for you. Meaning of retained placenta is when placenta is not delivered within 30 minutes after delivery. Now, how to manage it? Because this is an important cause of postpartum hemorrhage. So how to do the management? Okay, now see here. Apply controlled contraction to remove the placenta. Controlled contraction. So we already discussed this. Controlled contraction means with your one hand, you can gently give a sustained pulling effect on the umbilical cord, and with your other hand, you need to support at the suprapubic area so that there is no inversion of the uterus, and at the same time, because of this pulling effect, the placenta is separated and delivered out. This is called controlled contraction. One important point here is avoid okay avoid the forceful contraction and fundal pressure, as they may cause uterine inversion. So these are not done. If the placenta is not expelled, give 10 units of oxytocin IM if not already done for active management of the third stage of the labor. Oxytocin is a good drug to be given here just to make sure uterus is contracted, and it will help the pushing of the placenta outside. But do not give orgometrin. Orgometrin is another type of oxytocin drug, but we don't give orgometrin in this case because this orgometrin causes tonic uterine contraction. Tonic uterine contraction. There is no relaxation in between. It causes continuous type of contraction all the time, which may delay the expulsion of the placenta. Okay, so during this stage, ergometrin is not given. It is given only for the atonic, uterus because of some other causes, not because of the retention of the placenta. Make sure the urinary bladder is empty. I already gave a lot of reasons for the catheterization purpose. If the placenta is undelivered after 30 minutes of the oxytocin stimulation and controlled contraction, you need to attempt for manual removal of the placenta. Now, this is a difficult procedure rather than controlled contraction. Manual removal means you need to insert, one of the hand inside the uterine cavity and remove it. Let's move on. Now, let's talk a bit about manual removal of the placenta here, which is also known as MRP. So start an IV infusion. Start an IV infusion first. Okay. Provide emotional support and encouragement for that lady, because this can be a difficult procedure for her. It's a time-consuming procedure. Give pethidine and diazepam IV slowly, or you can also use ketamine. We want to sedate that lady. Okay, we want to sedate the lady by giving pethidine and diazepam. Pethidine is a very strong painkiller as well. Catheterize the bladder or ensure that it is empty. Always do that. Otherwise, there will be atonia of the uterus and there will be difficult procedure. Give a single dose of prophylactic antibiotics like ampicillin, 2 gram IV plus metronidazole 500 milligram IV, or cefazolin 1 gram IV plus metronidazole 500 milligram IV. Now, remember, this is a type of procedure, and any type of procedure, there is a chance of contamination, there is a chance of, infection. So to minimize the chance of infection, these antibiotics are used. Ampicillin and cefazolin. Ampicillin is a type of penicillin. Cefazolin is a type of cephalosporin. We all know that. So they may cover the gram-positive organism, whereas these anaerobes are covered by metronidazole. And they also cover a bit of, gram-negatives, ampicillin and cefazolin, though they are not having very good coverage against gram-negative, but nonetheless, they cover some of them. Hold the umbilical cord with a clamp. Pull the cord gently until it is parallel to the floor. So a bit of a procedure is explained here. Here. So introducing one hand into the vagina along the cord. So you, with one hand, you can simply pull the cord outside. Another hand is inserted into the vagina along the cord. Now, supporting the fundus while detaching the placenta. So with the hand which is inserted inside the uterine cavity, the hand is detaching the placenta, at the same time support the fundus of the uterus, and then withdrawing the hand from the uterus along with the placenta and the membrane. So this is known as manual removal of the placenta. Manual means hand. You are using your hand to remove the placenta because it is taking time to separate. So these are the different things we do during the procedure. Palpate the inside of the uterine cavity to ensure that all placental tissue has been removed. If any of the tissues are left behind, they can again lead to uncontrolled bleeding. So we have to make sure everything has been removed. Give oxytocin 20 units in 1 liter of the IV fluid, either normal saline or ringer lactate at 60 drops per minute. This is a bit of more of a practical knowledge for you. You don't need to remember this now. Just remember oxytocin is given. Ask an assistant to massage the fundus of the uterus to encourage a tonic uterine contraction. Massaging the fundus is really important one for the stimulation of uterine contraction. If there is continued heavy bleeding, give orgometrine. Now, orgometrine can be given here because you have already removed the placental tissue. Before the delivery of the placenta, orgometrine is not given, remember that. But after it can be used. Or even prostaglandin can be used. Examine the uterine surface of the placenta to ensure that it is complete. And if any placental lobe or tissue is missing, explore the uterine cavity to remove it. Never, leave just like that. And just to make sure whether everything is delivered, you need to examine the placenta, ask some of the junior to examine the placenta if you do not have enough time during that procedure. It is really, really important step. Let's move on. Now, let's talk about how to manage the secondary postpartum hemorrhage, also known as delayed postpartum hemorrhage. Okay, so we are towards the end of this important topic. Now, according to the definition or the meaning, increased vaginal bleeding beyond the first 24 hours after childbirth or within the puerperal period is called secondary or delayed postpartum hemorrhage. Delayed. Okay. The common etiology for this condition are retained bits of placenta again and infection like endometritis. So retained bits of placenta, the proper third stage of the labor, the proper management was not done. The obstetrician has left some membrane or bits of placenta inside. And another important one is endometritis. Now, how to manage it? The general management is same one, absolutely same. Okay, the same slide is repeated here because these are the different things we do here also. Perform a rapid evaluation of the general condition of the patient. Okay, measure the vital signs well, make sure she is stable. If shock is suspected, immediately begin the treatment by using ringer lactate solution. Okay, Ringer lactate solution. If she is severely anemic, arrange for blood transfusion. Catheterize the urinary bladder. Make sure placenta has been completely expelled, or examine the cervix, vagina, and perineum for the tears. Absolutely the same steps of the management which we talked before. Now, let's come to the specific management here. The first thing is give oxytocic drug. Who knows, the uterus may be flabby, okay? So make sure the uterus is well contracted. Give oxytocic drug. If there are signs of infection, if there is a case of endometritis, is a serious infection of the uterine cavity, which is manifested by fever, foul smelling vaginal discharge, give antibiotics as for endometritis, because that may be the cause of bleeding here. And these commonly used antibiotics are, see here, give a combination of antibiotics until the woman is fever free for 48 hours. And these are ampicillin plus gentamicin plus metronidazole. So all three coverage you have done here. Ampicillin for gram positive, gentamicin for gram negative, metronidazole for anaerobe. So ampicillin 2 gram IV every 6 hours, gentamicin 5 milligram per kg body weight IV every 24 hours, and metronidazole 500 milligram IV every 8 hours. See, all the medicines are given intravenously because this is a serious infection. If fever is still present 72 hours after starting the antibiotic, you reevaluate and revise your diagnosis. What does that mean? If these antibiotics do not control the fever, okay, or infection, I should say, even after 3 days of their use, don't just keep quiet. Don't say, oh, it is taking a bit of time to control the infection. Nothing like that. You reevaluate again. Who knows? Those bacteria are resistant to the antibiotic which you are using. Or maybe your diagnosis altogether is wrong. Okay? Some infection is occurring in other parts of the body or something like that. So, as a doctor, we always think in that direction. Now, other parts of the specific management would be if the cervix is dilated. See there, if the cervix is dilated, okay, then remove the large clot and placental fragment with the hand, because we can insert a hand easily. So who knows, those clots and those placental fragment are the causes of this hemorrhage. Manual exploration of the uterus is similar to the technique described for removal of the retained placenta. It's the same one. We have just talked about the manual removal of the placenta, right? So same type of things we can use here to explore the uterus. What may be the cause for this bleeding? If the cervix is not dilated, evacuate the uterus to remove the placental fragment. Some surgery also may be needed. Some curette may be needed now. Rarely, if bleeding continue, consider the uterine and utero-ovarian artery ligation or hysterectomy. Now see that these are the same type of steps now. If a simple type of procedure are not controlling it, we need to go for some complicated type of procedure, difficult one, bigger type of surgery, like arterial ligation or even hysterectomy. And don't forget to perform histopathological examination of the curating or hysterectomy specimen, if possible, to rule out the trophoblastic tumor. Trophoblastic tumor means hydatidiform mole, okay, also known as molar pregnancy or even choriocarcinoma. These are called trophoblastic tumor. So this is a common thing. This is a called as the common principles of any surgery. After you take out that specimen, you have to always do histopathological examination just to make sure what type of tissues are there. What is the cause of this infection or the disease like that? Now, we have reached to the end of this important topic. At the end, there is one complication of this PPH, which is known as Sheehan syndrome. but I'm 100% sure you already know the meaning of this. Okay, but still, let's talk about it. Now, this see here, the Sheehan syndrome is also known as postpartum hypopituitarism. Postpartum hypopituitarism. So, what is the meaning of hypopituitarism? What is the meaning?
So decrease the function of the pituitary gland means decrease the production of the hormones from the pituitary gland.
Excellent.
So basically,
Okay, excellent answer. So hypopituitarism is the decreased functioning of anterior pituitary, especially anterior pituitary, but the whole pituitary gland may also be affected. And this is simply because of the decreased blood volume, here, because a lot of blood has been lost during this postpartum hemorrhage. Okay, so as a result of this, there may be decreased perfusion of the pituitary gland. And one important point you should never forget, during the pregnancy, the size of the pituitary gland has become bigger. Okay, it is bigger. So that amount of blood flow which is there in the pituitary gland may not be enough after this postpartum hemorrhage. Now let's move further. It is hypopituitarism, that is decreased functioning of the pituitary gland caused by necrosis due to blood loss and hypovolemic shock during and after the childbirth, and that is done by PPH. So this is a necrosis, or you can understand decreased blood flow to the pituitary gland. Most common initial symptoms of Sheehan syndrome are agalacturia, which is called absence of the lactation, or difficulties with lactation. Now, which hormone is responsible here? Which hormone?
sir, the prolactin from the anterior pituitary.
Prolactin.
Excellent. It is prolactin. Very good. Prolactin. Okay. This is prolactin, because prolactin hormone is very necessary here for the production of the milk. And for the ejection of the milk, we need oxytocin. But mainly it is responsible, okay, when is the prolactin here. Many women also report amenorrhea or oligomenorrhea after the delivery. Now, what is the reason for this now? Amenorrhea or oligomenorrhea? What is the reason?
So basically, sir, there's a decrease certain hormones due to which there will be amenorrhea.
So decreased production of FSH and
Yes,
LH.
sir.
That's why there is decreased
Yes, sir.
amenorrhea.
Exactly, absolutely. These are the other hormone which are released by anterior pituitary, FSH and LH, because the whole anterior pituitary is gone here, So without FSH and LH, the gonad, especially in the female, we are talking about ovary here, cannot function properly. So resulting in amenorrhea or oligomenorrhea.